I'll be presenting the study evaluation of the safety and effectiveness of the sub 400 protocol in corneal collagen cross-linking, a 2-year follow-up study. No financial disclosures. It's clearly documented that reported cases of keratoconus is increasing over the years. Probably more identification is happening due to better available investigative modalities. For more than 2 decades, the first line of management or treatment for progressive keratoconus is corneal collagen cross-linking, which has proved itself as a very safe and effective modality of treatment. The conventional protocol of procedure that was followed is the Dresden protocol as introduced by Wollensack in 2003. Even now, this is considered the standard protocol, but modifications to its formulations and administrations have been proposed to overcome shortcomings of the original epithelium of Dresden CXL protocol, and also to increase its applicability across various clinical scenarios. One of the most accepted modification is the accelerated C3R, which helps in reducing the long time of exposure of the deepithelialized cornea, which can pose a risk for infection. So efficacy of the accelerated protocols were initially questioned, but enough studies have come up showing the efficacy and safety wise it is comparable with the standard technique. So another major obstacle was the minimum thickness criteria for standard as well as the accelerated protocol. The studies have shown that the average thinnest Pachy at presentation is around 440 microns, which clearly makes that at least 25% of the keratoconus patients are denied a chance to stop progression by cross-linking. Why there is worry about thinning cross-linking in thin cornea is because of the potential complication of endothelial failure. Various protocols have come up for cross-linking in ultra-thin corneas, but it has its own sets of limitations. The latest among this is the individualized protocol by Hafizi et al., in which the treatment time is individualized without affecting the intensity of cross-linking at the desired depth. The very few studies have come up regarding this protocol, of which the only Indian protocol designed is from Dr. Rohit Shetty et al., which was named as the next generation cross-linking for thin corneas, for which a calculator is also available online for easy access. Our aim was to study the safety and efficacy of this particular protocol in our population, because Hafizi's protocol was studied mostly in the Western population. Ours was a retrospective case series of progressive keratoconus cases. We followed standard criteria for progression that is described in literature as given here. We included only those who completed 2 years of follow-up, and we avoided non-keratoconus etiology for progressive ectasias. The details of the machine, riboflavin, and topography used for the study are as given below, and studies are done at the same center, same surgeon. We used 9 milliwatts in all the cases. The soaking time was 30 minutes. This was the follow-up schedule. All the patients could not come for all the visits, but we included only those who completed 2 years of follow-up in the final results. Our outcome was mainly focused on 2 factors. One, the efficacy, for which we checked the K values, the thickness, and the BCVA. And secondly, for the safety, for which we looked into the haze, the endothelial failure, infection, and the drop in BCVA. We used Fantas et al. Grading for grading the corneal haze. Coming to the results, 42 eyes of 36 patients completed our observation period of 2 years. Mean age was 27 with slight male predilection. 6 patients had bilateral procedure. Mean value of BCVA was 0.41 on logMAR, which is 6 by 15. K mean was 49 and K max was 59. The thinnest Pachy was 426. Coming to the changes in the parameter at 2 years follow-up, a reduction of values noted in all the 4 parameters. For better representation on graphic, on chart base, the reduction of values in all the 4 parameters depicted on charts, which implies significant changes in the thickness and K values, showing thinning and flattening, but no change in the BCVA was found to be significant. When we say that significant drop in the K value, it implies that there is flattening and no progression in ectasia, which in percentage in our study was around 90.5%, which also implies that our failure rate was 9.5%. Though the failure rate in literature for standard protocol for more than 400 micron thickness is 7%, which means that even in the safe range of thickness also has a 7% chance of failure rate. When we looked into the subgroup of failed cases, out of the 4 patients, 2 had a pregnancy in the post cross-linking period. 1 had severe uncontrolled ocular allergy. And the last case, no known local or systemic causes could be identified, except that he was severely deficient in vitamin D, for which he was taking treatment, which can be associated with his progression probably, as in keratoconus, it is reported in literature, as given the reference given below. When you look at the distribution of the BCVA, majority of the patients didn't have change in the vision. 28% had mild increase in vision, probably explained by the flattening of K values. No significant drop in vision is shown in statistics, but we consider 2-line loss as worrisome, and 3 patients who had that was among those who had the progressive ectasia. We didn't have any case of infection or endothelial failure in our series. Among other adverse events noted were the post-operative haze. There was significant number of patients with postoperative haze of grade 2 immediate post-op, which reduced significantly over a 2 years time of follow-up. There was no impact of haze on the BCVA, as grade 3 and grade 4 haze was not at all documented in our case. Only 2 or 3 reports are available in literature about this protocol, in which there is no study validating the NXT protocol proposed from India. In comparison to other published literature, we could see that our study is comparable to them in number of patients, the stability, the endothelial safety, and observed mean values in Kmax, thickness, and BCVA. We had the advantage of a longer follow-up than the other study, but the lowest pachymetry we selected was slightly higher than the lowest pachymetry range showed by them. To summarize this study, it was an attempt to validate a protocol, new protocol that was proposed for progressive keratoconus, a sub 400 protocol, especially regarding its safety and efficacy. No previous study was done on this. The study matched the 2 available international literature on this topic. There are limitations, especially we didn't have a lack of a true matched thin cornea control group. And we plan to continue this work in future with a prospective multicenter trial, and to also to look into the other systemic causes like vitamin D deficiency, which may be also contributing to the failure. The implications are that the result of the new nomograms are looking promising and safe, which makes more keratoconus patients eligible for cross-linking. Treatment makes sense only if your useful vision can be provided for such patients. And the implications of this study is that we get a chance to do vision correction refractive lasers also in such cases if they are more safe. Higher failure rates should be investigated in more detail. Thank you very much.
Thank you so much, sir. What was the average demarcation line you got in your series?
Yeah, actually, I didn't measure that because I didn't get a demarcation line in all the cases. Initially, I've looked into it. I didn't take it in the results because I have not considered it in the primary as a outcome measure. And all the cases didn't have a proper documented demarcation line.
And sir, when you are saying haze was there in 40, I think out of 42, was it the normal classical or the expected haze that we see after CXL, or was that a significant haze even visible on slit lamp?
Yeah, what I tried to compare was with that post-operative haze of the PRK. According to it, the grade 1, grade 2 haze was the most common, which we normally see in the first 1 week, and it used, after 1 month and all, it was slightly reducing, and at 2 years follow-up, none of them had significant haze, which actually contributed to the loss of vision or loss of BCV in such patients.
Age groups. Age group.
Our mean age was 27.
27.
Presentation as usual. Just 2 questions. So one is when you talk micronutrient deficiency is something that we're now screening for pre-CXL. Are you looking at those as we're doing it routinely for patients who present with keratoconus before we cross-link? Are you also have you started looking at biotin, magnesium, and thyroid pre-CXL?
No, sir. Actually, right now I'm looking into zinc and vitamin D for the last 1 year. Right. I'm keeping a track of that.
And the second question is, sir, have you seen any stromal sclerosis post in your case?
No.
Or in your other cases, other CXL cases?
Not really. I didn't say that.
Not yet.